moving now on to the management of JIA, I would like to request Dr. Priyankar Pal sir, Organizing Chairperson of NCPR, Professor and HOD of Pediatrics at Institute of Child Health, Kolkata, to come on the stage.
So, very good afternoon, everybody. From the research papers to the basics, grounded work. The challenges that we face as pediatricians, as pediatric rheumatologists. So the challenges that we face in India. Now, you see from the textbook of Petty and Cassidy, chronic arthritis in childhood is a complex area of study, and not least because of the inconsistencies of definition and terminology. So it starts with this. So let us have a classic case. So this is an 11-year-old girl who presented with fever for 3 months, anemia, progressively increasing leukocytosis, high ESR, CRP, treated by pediatricians, extensive investigations done, but even in my institute, there was no referral to the pediatric rheumatology department. So receiving antibodies, antibiotics, multiple antibiotics, different courses, so without, again, a referral. And finally, we arrived at the diagnosis of SJIA. So by that time, you can see valuable resources have been spent because the money that we have is a limited amount of money. So a lot of money has already been spent on investigations which were sometimes unnecessary, and multiple hospital admissions and expensive antibiotics. And again, the child needed biologics. So SJIA patient needed tocilizumab. Now there was an affordability issue. They had irregular follow-up subsequently, compliance issues. And finally, after a year, the child landed with a tuberculosis, so a secondary infection. So challenges that we face on day-to-day life, challenges in diagnosing, wrong diagnosis, then correct diagnosis, compliance, multiple challenges. So I won't go into the criteria of the classification, but again, the most important thing that this is a very, very subjective classification or a subjective diagnosis. So it's a heterogeneous group of diseases that encompasses all forms of otherwise unexplained chronic arthritis. So unexplained chronic arthritis. So you need to exclude the causes. So let us start with the case, the mimics. So this is a 9-year-old child who presented with pain in the right ankle for 2 months. You can see the initial investigations. I would like to point out the lymphocytes were on the higher side, if you look at the differential. The child came to Kolkata in a different center, diagnosed as JIA, received a short course of steroids, methotrexate, not responding. Finally, August 2021, landed in our center. So these are the investigations, nothing very significant, but the X-ray showed there was a metaphyseal region, there was a periosteal reaction. So we were thinking in lines of a malignancy or a non-infective osteomyelitis, a CRMO. A bone marrow done, bone biopsy was done, so nothing came out. Malignancy could not be established. The child was followed up on naproxen, but the child went to a different center where again they were thinking of CRMO. They did a MRI, whole body, and there was multifocal osteomyelitis throughout. And they decided to treat in lines of CRMO. The child received pamidronate, etanercept, intermittent flares were treated by steroids, and this continued for some time. And July of last year, they come back to us again, and now the child has pancytopenia. You can see 1,700 total counts, 63,000 platelets, and a jaundice. The child was again worked up, a bone marrow aspirate, yielded a dry tap, and finally the biopsy established a diagnosis of a pre-BALL. So remember that leukemia, the commonest childhood malignancy, can just mimic JIA. So a red flag will be Definitely we know disproportionately low hemoglobin, low platelets, high ESR. But if you look at the initial blood count, a lymphocytic preponderance in a phase of an inflammatory disorder, if you look at it, it will always be taken with a lot of caution. And we all know the nocturnal pains. So GIA pain is the morning stiffness, but if you have a patient with pain at night, always be very, very cautious. And no amount of caution is enough before administering steroids. We have encountered multiple situations where marrows were done in different centers throughout India, and finally the leukemia was diagnosed months later. So other malignancies, you can see neuroblastoma can present with bone pain and arthritis, and then Langerhans histiocytosis, LCH. So these are the classic skin lesions of LCH. So rheumatology is all about recognizing a pattern, so to coming at a diagnosis. And the markers, the blood tests, they really do not help in establishing a diagnosis of JIA. So they have some prognostic value at the most. So from leukemia, you can have bone dysplasias. So these are a spondylometaphyseal dysplasia presenting with deformity of the joints, swelling. And then again, you can have multiple DDs from inflammatory bowel disease presenting with arthritis to immunodeficiency disease presenting with arthritis. So challenge number 2. So we had looked at the mimics, and now we look at the unusuals. So if you look at the diagnostic criteria of SGI, this was the ILR one, and then you have the Printo one, where the first time they introduced a leukocytosis, a blood count, and neutrophilia. So we know all that the classic SGIA rash is an evanescent rash. It comes and goes with the fever. But what you have a small baby, a 6-month-old, who has an evanescent rash, but which is intensely itchy. So we had a huge session on autoinflammatory yesterday evening. So definitely you'd like to look at the genetics of this patient. And the sick child in the intensive care. So this is a 3-year-old baby, 3-year-old boy who presented with history of trauma to the left foot with shortness of breath for 5 days. You can see blood counts are elevated, neutrophilic leukocytosis, high inflammatory markers, and there was ascites as well as pleural effusion. So with the background of a trauma, the intensivists were hell-bent that this is nothing but a disseminated infection. So you can see the focus done. Fibrinous exudate in the pleural space. So they went on treating with antibiotics again. It was only when the platelet counts were going up, we said, please let us treat it as as a SGIA patient, because serositis is again a presentation of SGIA. And we know that again that arthritis can appear months later. In fact, this patient had arthritis several months later. So fever, we always in pediatrics, we tend to think of antibiotics and infections as a cause of fever. So it's time that we should look beyond our regimen of Mero, Vanco, and Doxy in treating the fevers. This was also a very unusual presentation of fibrinous pericarditis, presenting SGIA presenting as a fibrinous pericarditis. So in pediatric rheumatology, remember that uncommon problems are standard. Challenge 3, the ASO conundrum. So we have a fixity almost with the ASO, even after 80 years has gone by since the Jones criteria were established. And this adds fuel to the fire that a sore throat can lead to a broken heart. So look beyond the ASO, because almost now rheumatic fever is very, very rarely we see nowadays. The challenge 4, the infectious mimics of arthritis. So we have a lot of tropical infections, and many of them can mimic arthritis. And I'll tell you a small little story. This is a child, 15 years, who had presented with arthritis of the hands and a tenosynovitis. And just the day before I was leaving, they came to my clinic. The mother told me she had a biopsy done. I said, what biopsy? So there was a hypopigmented patch behind the ears, which I never saw, and it was Hansen's. So Hansen's manifesting with tenosynovitis, and never forget HIV. So if we look at the infections, this was a paper, but it shows that actually patients with JIA did not really have much infections than compared to the general population. But again, we know that a lot of this immunosuppressed patients can, because this was a patient of adenovirus we had presented, who had presented with MAS following an adenovirus infection, and this is a disseminated chickenpox. A patient is JIA on steroids. So that comes to the challenge of vaccinations. Are we really pushing vaccines in these patients? That we have to remember that a lot of these children definitely needs a lot of vaccinations to be coaxed almost. Tuberculosis always remains a challenge for us, and especially patients with on biologic therapy. But this was a paper, you can see that really the study revealed low rate of active tuberculosis in patients using biologic therapy. This was a paper from Dr. Ram and Dr. Suma, you can see the names over here. Challenge 7, not looking beyond the joints. So one has to remember that GIA also affects the eyes. So if you have a painful red eye, that always draws an attention. It's an ERA patient. But one has to remember the chronic debilitating uveitis that can come with blindness. So that has to be remembered. And one must also remember that there's no correlation between the severity of arthritis and uveitis. The vanishing numbers. We see that the estimate is that almost 350,000 children in India are suffering from GIA. So we have around possibly 100 pediatric rheumatologists throughout the country now. So everyone should have a database of around 3,500 children of GIA. If you look at the numbers from ICH, we have around 400 plus. So where are the rest of the children going? So orthopedic surgeons, pediatricians, adult rheumatologists, physiotherapists, and alternate medicine, we all have to remember. This was a paper from Dr. Sujata and Manjari, factors impacting referral of GIA patients to tertiary hospitals. And you can see that the group B, which was actually referred later, they had a much delayed referral compared to the group of patients who were coming initially to the pediatric rheumatologist. And we have to remember that this is a disease which needs therapy from the very initiation to prevent deformities. So as a community, I think the pediatric rheumatology community needs to be more visible. So presently, I think we have around 9 centers offering training across India, and possibly over the coming years, we need to increase this number of training centers. Challenge 9, therapy. So methotrexate has been used in GIA since 1992. People who use it knows that it's a safe drug. But for someone who does a Google, it's an anti-cancer drug. Doctor, you are prescribing an anti-cancer drug for my child. Even when I started first prescribing, one of my very senior colleagues asked me, will you prescribe this drug for your son? I said, yes, of course, it's a safe drug. It's an established drug. Why should we be using it? But remember that it's a once a week, because toxicity, if sometimes patients fail to understand well, they can give daily methotrexate. And we had this one patient who presented with severe pancytopenia and mucositis following this. What when methotrexate fails? This was a study done by Rakesh. The economic burden, you can see he comes from a government hospital. Even there, he said that provisional cost analysis revealed considerable economic burden, which was higher in systemic onset GIA with the use of biologics. And one of the things that he had taken into is the cost of transport and accommodation. One has to remember that some of our patients, they come from very far off, 200 kilometers, 300 kilometers. They have to travel, maybe they have to take a day's off to come to us. So necessity is the mother of innovation. So, and something which is very well known in India is cheap and best. I don't know how much it applies, but we have to possibly look for some other recommendations from our side. Intra-articular triamcinolone hexacetonide, Gajalakshmi just presented. We had a study of leflunomide, which showed that leflunomide along with methotrexate was effective in almost 67% of the patients. A cheap drug, cyclosporine, which we were using before tocilizumab came in. We still have some of patients using cyclosporine. Biosimilars, I think Satish will be speaking on it tomorrow. Tapering of biologics, this is the Indian system that we follow. Thalidomide, lenalidomide, some of the centers are using. Tofacitinib, we have been using for the last 2 years with not too bad response. There is nothing so confining as the presence of our own perceptions. And so I think the time is for an Indian Pediatric Rheumatology Society consensus. So I request the executive body to think of coming up with a consensus for the Indian patients. We have a huge patient population. Caregiver burden, we have to remember that, yes. So this was a study which showed that caregivers from rural areas face disproportionate economic problem, often aggravated by losing jobs due to caregiving responsibilities. So it's a chronic disease, unpredictable disease, and one has to remember that the likelihood of achieving a remission has several factors, including how long you are treating the child, how long you initiate treatment. So it's a treat to target nowadays. So dream in light years, challenge miles, and walk step by step. As a society, I think we have started walking step by step. So now we need to increase the strides. Thank you.